right, welcome everybody to the Playing Games podcast, episode 23. Today I'm joined by a very special guest, Dr. Huub Maas. How are you doing today, Dr. Maas? Am I pronouncing that right?
Dr. Maas is fine. Yeah, Huub is a typical Dutch name, so I'm doing fine. Thank you.
Yeah, thank you for joining us today. Just to get things started, why don't you tell us a little bit about yourself and a brief introduction of your experience within the field of muscle physiology and things like that.
Yeah. Well, so the department where I'm at now, Human Movement Sciences in Amsterdam, is also the department where I got my master's degree. And after that, I also did my PhD degree here in Amsterdam on muscle mechanics. After that, I did several postdoctoral fellowships. I moved to the US in Atlanta, working at the Georgia Institute of Technology. Then at Northwestern University in Chicago. And after that, I moved back to Amsterdam and back to the department where I'm now, and I'm still working at the moment as an associate professor.
That's awesome. And Georgia Institute of Technology and Northwestern, from what I understand, are really, really good schools when it comes to muscle mechanics and topics such as that. How was your experience over there with those universities?
It was really good. It was a really I did my PhD focusing mainly on muscle mechanics, but I actually also went to Georgia Tech to also broaden my fields and include more neuromuscular control. I worked there with Professor Robert Greger and Boris Prilutsky. And so they introduced me to a different type of measurement techniques, but also different theories regarding neural control. So also more the sensory side of muscle. We often consider muscles as the actuators of movement, right? So, but muscles also consist of a lot of sensors that are important for controlling posture and movement. And so I got introduced to that field in Atlanta. I think they're both very good institutes, but I think most important for good postdoctoral fellowships is good advisors. So I was really lucky with the people I got a chance to work with. In Atlanta, this was also with Professor Richard Nichols. And in Chicago, I worked with Thomas Sendercock and C.J. Heckman. And they all gave me kind of great possibilities to explore my own interests and design own experiments and prepare me for the next step in the academic career. So that was really, really good.
Yeah, I think having a good advisor is very important if going for a PhD. I've heard of Ben Prilutsky over there. I've seen some of his work. He seems to be one of the leaders when it comes to motor control and things like that. So what kind of work do you focus on now specifically? What have you tuned your expertise into at the time?
Yeah, so I'm still combining both the mechanical and the neural sensory side. So I have projects on effects of, for example, muscle stretching, on muscle mechanical, but also muscle morphological properties. I am slowly steering to trying to get more work done in the sensory function of muscle, trying to understand how changes in muscle structure also affect sensory feedback, and then consequently also play a role in the proprioceptive deficits that we see, or the balance impairments that we see in some patient groups. And I also have projects that are more directed towards like motor control and understanding neuromuscular control. Also, for example, after a stroke or like other pathologies like cerebral palsy, for example. Yeah, so quite broad, but yeah.
All of them sound interesting. The stretching one, could you elaborate a little bit more on what you mean by looking into the stretching, like how muscles respond after being stretched
Yeah,
for a
so we
while?
looked at different types of stretching. So, of course, stretching is something that is done a lot. Stretching is applied of course, in sports, but also in many clinical areas. So, we were predominantly interested in stretching as a treatment strategy um, in joint contractures, for example, also in like cerebral palsy, but also after stroke, or if you have been immobilized for quite some time, you can have like your range of motion is decreased, and then stretching is applied. But then there are many different types of stretching that you can do, and then of course, what intensity, what is the duration, uh, yeah, so that's one of the things we wanted to know, and we were specifically interested in differences between static stretching, so holding the position of a joint like for a certain amount of time statically, or applying like a constant torque around the joint, so you can very slowly move the joint towards a different position, and how that differs. And there's been an interesting project. We started with animal experiments to do very controlled measurements on single muscles and stretching, giving them different stretching paradigms and looking at the differences in changes in muscle morphology and mechanics. Um, and we're now trying to move this towards the clinical populations and see if we can also look at the differences between the different types of stretching. For example, in patients with cerebral palsy, often plaster casts are used to correct the more plantar position often children have. But maybe this more like a constant torque type of stretching could be a better way of doing this. The advantage seems to be that you can have a lower peak load applied on the joint. So you slowly stretching the tissues, and with some of the other techniques, you go towards like a maximum range that a person can resist or can tolerate. Often, yeah, towards the pain threshold. Um, but then we know mechanically that if you hold it on the same position, that the load actually decreases quite quickly due to the kind of the viscoelastic properties of the muscles and the tendons and all the other structures around the joint. So that's where we are now at. So we're preparing like now studies in patients to test these ideas.
I think it'd be very cool to read those studies once they come out or available to the public. But today, specifically, we have a topic that you have had quite some work in, uh, which is lateral force transmission.
Yeah.
Do you mind kind of going over what lateral force transmission is?
Yeah, so lateral force transmission. This is the term that was introduced in the 80s by Sybil Street. Later on, like my PhD advisor, Professor Peter Haring, introduced the term myofascial force transmission. They are both kind of the same, like a different term for the same mechanism, and it means that besides the transmission of forces, for example, within a muscle fiber from sarcomere to sarcomere, that there is also like a parallel pathway that forces can also be transmitted. In this case sideways, so that's why the term laterally to like the extracellular matrix, for example, and then towards the muscle, the connective tissue network and the tendon. This can be found like within a muscle or within a bundle of muscle fibers. And we have also studied this, and this was my topic of my PhD, and I've been studying this since then. That it can also you can also have force transmission between muscles and other structures outside of the muscle boundaries.
Hmm. So what is kind of being understood now is that muscles are said to transmit, because muscles transmit force both longitudinally and laterally, correct?
Mhm.
However, it's been kind of stated that most of the force that muscles transmit is laterally rather than longitudinally. However, I was kind of skeptical on that because from what I've read, and I think this started with like Faulkner, some of his work, um, that most of the studies, if not all of the studies, that find this increase in lateral force transmission to be greater than longitudinal force transmission always has methods that interrupt the lateral force transmission. I don't like cutting the tendon or things like that. So, would you say that most of the force is transmitted laterally, or could most of the force be transmitted longitudinally?
Yeah, I think it's a difficult question, and maybe it's good to start with like the very first experiments that were done on lateral force transmission were like in like a bundles of muscle fibers from a frog. This was the experiments by Sybil Street in the 70s and 80s. And they had like a preparation where they had like half of a muscle bundle intact, and then the other half there was only like one single fiber, and then they stimulated only the single fiber. And if you pin both ends of a fiber and you measure a certain amount of force, then they assume that the force was produced by that specific fiber. Then they repeated that experiment, but then they did not pin down the end of the muscle fiber, but the end of the surrounding fibers, like the kind of leftovers. And then in that situation, they still found like 75% of the force that compared to the initial case. And the only reason, the only explanation for that is that the sarcomeres that were within that bundle of muscle, intact muscle fiber material, would kind of be laterally connected, so they would kind of hold themselves towards the surroundings, and therefore they could still produce force. Um, but this was more like the proving the concept, right? So this showed that the sarcomeres and muscle fibers, they are not acting individually. They are not completely separated or isolated from the surroundings. In some old textbooks, you can read that the connective tissue matrix, and you can sometimes compare this to kind of a honeycomb structure. You have all these tunnels of endomysium where you have muscle fibers in, and there were once it was thought that these tunnels would allow like individual movement of the muscle fibers with respect to each other. And this classical experiment showed that there were clearly connections from one fiber to the other. But again, here this was tested in a case where you had disrupted the longitudinal pathway to show that the lateral pathway is present. And the other work that has been done to kind of explore that same question, like how much is transmitted laterally and how much is transmitted longitudinally, is also done in a similar kind of way. The work indeed by John Faulkner's group, they also they disconnected the longitudinal pathways and then showed that via the lateral pathways, the muscle could still function and could produce a large amount of force. I think in some way this is kind of an impossible experiment, because if you have two mechanisms that can contribute, but they can compensate for each other. So if you remove one mechanism and then you still see force transmission, it doesn't mean that mechanism is the major determinant. It just means that it can also take over the function of the longitudinal pathway. To me, it still makes most sense that the longitudinal pathway is the major determinant of force transmission. But having all these sarcomeres in series, like all these little functioning units in series is also a quite unstable system. And I think it is definitely necessary to anchor all these little components laterally to make the system more stable and functioning more in like a homogeneous way. We see that nicely when you make longitudinal sections of muscle fibers. You see that all these sarcomeres are nicely aligned, right? You see all the Z lines nicely aligned. Yes, something like that can only happen if you have these lateral connections. Whether that means that all these lateral connections continuously transmit the forces from the sarcomeres to the outside via these pathways, yeah, I don't think so. One reason is also that theoretically then all these sarcomeres in series would not be acting in series but could act in parallel, and that means you would be able to produce much more force than our muscles do. So I think that's maybe not fully the answer, because it's very hard to investigate this. People sometimes apply models to see if they can test it, but also with models you determine the ratio of the different pathways by providing stiffnesses of structures, and you also cannot prove that one mechanism is stronger than the other one.
So you bring up a good point about creating stability in such what seems to be a compliant system, right? So this lateral force transmission, well, actually before that, so it makes more sense that most of the force is likely transmitted longitudinally, and the studies that people usually read that most of the force is transmitted laterally comes from papers that disrupt this longitudinal disruption. So it looks like most of the force is transmitted laterally, but the key is in the methods to show that there was some disruption to the longitudinal pathway. Now, for force production, this is where I'm also kind of iffy here. I don't know how confident I am in really seeing how lateral force transmission increases whole muscle force. There has been some talk about that from what I've heard. But I've also heard that it more so doesn't really impact whole muscle force. It mostly impacts, like you said, the stability of these functional units, these sarcomeres. Do you have any thoughts on any of that?
So maybe coming back first to the experiments that have looked at disruption. I do think that this mechanism is very important when you do have muscle damage, for example. So that's a different topic. But if you have damage to muscle fibers, then, and that's what I have previously described, also in some of the papers, is to see this mechanism as a safety net, right? So it can create a bypass around a injured area. It can provide like an acute solution to disruption of muscle fibers or tendons to minimize the impact of it. So from that perspective, the importance can definitely will definitely grow if you have muscle or tendon damage. So regarding the impact on like whole muscle force production or force capacity, well, there are different mechanisms via which this could take place. But one thing is, if you have all these muscle fibers, they act in parallel. If you have large distributions of the length of the muscle fibers, then their peak force will be at different lengths, and that means that the sum of the forces of all these muscle fibers will be less high than if all the muscle fibers are acting kind of more in unison. So keeping that distribution between muscle fibers and within muscle fibers, minimize that, is also creating a higher force of the whole muscle. if you think about muscle groups, then it can of course happen that some of the force that one muscle is producing and it's transmitted to the other muscle can then increase the impact and suggest that the muscle has a higher force output. But this may not be actually the case. An example that you that you can see can kind of experience yourself is if you test the forces that you can produce by your individual fingers. If you test each of the fingers separately or all the fingers together, then yeah, you can produce more total force with each of the fingers separately. And this probably means that some of the force that you measure when you measure one single finger is not coming from the muscle fibers only linked to that specific finger, but that some of the forces from the other fingers is also going towards that specific finger. And we use that mechanism when we are, when we grab something with 3 fingers, we actually can exert much more force on the active fingers due to some of that force transmission. But of course, the total capacity of muscle force production is not changing. It's more like it's redirected to a different site on our skeleton. Thereby, it has a different mechanical effect. Does that make sense?
Yes, that does make more sense to me. I know one theory or mechanism that was thought to say how lateral force transmission increases whole muscle force output would be to the addition of adding sarcomeres in series, because when we add sarcomeres in series, the theory goes that we are also adding costomeres that are clipping to the end of those added sarcomeres, and then when we have more costomeres, therefore we have or therefore adding sarcomeres in theoretically would increase whole muscle force output. But from all the data that I've seen, it's kind of very well agreed that adding sarcomeres in series doesn't increase whole muscle force, at least asymmetrically. It's adding our sarcomeres in parallel. So I wasn't sure about that theory, and it seemed more to me that if these sarcomeres were added, it played more of a role in anchoring these structures and stabilizing rather than increasing whole muscle force. Would
Yeah,
you?
yeah. And so in theory, this is definitely possible. So as I said, like if you have if you have 2 sarcomeres in series and they can only act in series, then the strength of the 2 sarcomeres can never be more than than the force produced by the weakest link, right? So if you have only 2 in series link, if both sarcomeres are acting parallel, then you could in theory sum the forces of the sarcomeres in series. I think, but part of this, like there is some literature like that is and still people are working on like what is the relationship between changes in muscle cross-sectional area and changes in muscle force output, for example, and by finding correlations that the cross-sectional area could not fully explain the changes in the maximum force production. People thought, well, what could be other mechanisms? And so it might be that some of this is happening. That you could have if you do have more lateral linkages and you do have a little bit more of that parallel pathway being active, then that's a possibility. But I don't think that has been proven so far. So it's still like a theoretical mechanism to explain something that people like a correlation that is not fully explaining what they see. And of course, you always want to come up with alternative mechanisms, and this is one of them. But proving this is quite hard.
Yeah, and I think a deeper dive into this mechanism, there are still a bit of I think flaws within it that doesn't like really have it be at a strong ground to be like, yeah, this must be the mechanism to explain this, right? I did want to ask, where are we kind of now with our understanding of lateral force transmission? Because we've had a history with it, like you said, where it first started. How has it progressed, and how has our understanding of it changed to
Yeah.
this day?
Yeah, that's a good question. So, well, it started and was initiated more um, to think about like what is the role of these proteins that connect the inside of the muscle fiber to the excellular matrix and the connective tissue, focusing on force transmission within muscle fibers. Um, and people have looked at this mechanism with relation to several like diseases. One of these proteins that is very important is dystrophin. So in diseases like muscular dystrophy, um, yeah, this mechanism is plays a role also in the pathological condition of the muscle. Um, and then this concept was actually transferred to like the question, could this also play a role outside of the muscle boundaries? And that's one of the steps that my PhD advisor Peter Heying took, and that's also when I started in this research. So my own research focused more on the connections between muscles and all kinds of connective tissue that is surrounding muscles, and how could that influence muscle function. Uh, the very first steps was actually showing that there was any force transmission. So in classical studies, looking at muscle mechanical properties, you would connect a tendon of a muscle to a force transducer and would, for example, measure the force at different lengths, or you would measure the force at different velocities to get the force velocity and the length force relationships. And what we did is we now also we connected not only the tendon of origin or the tendon of insertion, but we connected both ends of a muscle to force transducers, and see if you keep the surroundings of the muscle intact, if these the forces at both ends of the muscles would be equal. And we found in many cases that force exerted on one side of the muscle was not equal to force exerted at the other side of the muscle. And that can only be explained by mechanical interaction with the surroundings. So that was kind of for us the most direct proof of force transmission via the outside boundaries. And that also kind of created the term epimuscular force transmission. That's also used because it's transmission via the epimysial layer of the muscle, the outside layer of the muscle belly. And another result that we focused on is what happens if one muscle changes length. Does that also affect the forces on a muscle that is not changing length? And this is relevant because we have many muscle systems in our body where some muscles are crossing one joint, and other muscles that are in the same group cross two joints. For example, our calf muscles with the gastrocnemius and the soleus muscle. The soleus muscle is only crossing the ankle joint, but the gastrocnemius muscles are also crossing the knee joint. So the knee joint movements are actually only lengthening the gastrocnemius muscle, and then we wondered, would this also affect the soleus muscle? And there are many different systems in our body that have the same, like in the hamstrings you have muscles that also cross the hip joint, and the quadriceps have the rectus femoris that's crossing the hip joint. So that's often present in our body. So we first tested it in more like, it were like conditions that were more or less beyond physiological. So that would be like involving relative positions of muscles that would not be happening in during normal movement. And that was more or less my PhD. And after that, I moved on by testing conditions that were more close to resembling conditions that would happen during normal movements. And what you would see there is that the effects are smaller and not always clearly present. And Yeah, so how do I say this? Well, so the effect was smaller, and it really depended on the different muscle groups. And they were also dependent on the level of muscle activation. So in the animal experiments, we could test, of course, both passive and active conditions. Um, and so if we do it during active conditions, we would still see some force transmission, but in passive conditions, it was really small. And the next step, actually, what people have taken is then to test this in humans. My own work has predominantly been done on using animal models, but some experiments on humans as well. But other groups have taken that same paradigm, testing the interaction between monoarticular and biarticular muscles, for all kinds of systems. So in the upper arm, in the legs, and ask that same question: Can we see any? Can we identify any changes in the state of the muscle that is not changed length? And that has led to some mixed results. It's not always clear. It's also not always of a substantial size that you think, oh wow, this is important. But there are also many studies that do find indications of mechanical interactions in vivo within the human body, but mostly tested in passive conditions. And I think that is a little bit the current state, but it leaves it a little bit the question, like, what is the importance during active conditions? And I haven't seen many studies that tested this in active state. And the problem, of course, there is that it's very hard to do this in humans in a controlled way. You cannot do it the same way as in these controlled animal experiments.
I'm actually glad you brought up some of the points about the gastrocnemius as well. There was some topic, or I spoke with another researcher, where people would think that just because you're lengthening one muscle, it means you're only affecting that muscle. However, the researcher brought up, he goes, let's take the triceps, for example, and because this is the example that we were talking about. If we are overhead and we lengthen the long head of the triceps, there's the medial and the lateral head that don't attach to the shoulder or don't cross the shoulder joint. So they aren't really lengthened by the overhead position. But because the long head is, that lengthening of the long head seems to affect the forces at the other two heads, at the lateral and medial, or the force transmission of the other two heads. And that theoretically can affect the activation of those heads as well. So you're not just affecting one muscle when you lengthen it, you affect the nearby muscles as well due to changes in the muscle length, right?
Mm-hmm. Yeah, so the concept there is that you, by changing the length of one muscle, that is like, well, they are mostly muscles are grouped, like synergistic muscles are grouped, like the triceps surae or the biceps and the triceps, and they are kind of together in like one muscle compartment. If then one muscle is lengthening and the others are not, then the position of that muscle relative to the other muscles is also affected. And this is one of the ideas, that if you are changing the position of one structure versus the other, that the tissue in between is then being sheared, and therefore you get tension on the tissue between these muscles, and that would be the mechanism that one muscle is then also mechanically influencing the neighboring muscle. And the most clear case is when you indeed have like one muscle that is affected by, in this case, the shoulder joint, and the other muscles are not. Then still the muscle belly of that muscle is changed position, and that could also mechanically affect the other two muscles, and thereby also their functional outputs, for example.
And so with our current understanding of lateral force transmission, as you were talking about, aside from its beneficial role in muscle damage or after damage, um, is there anything that it could also benefit us clinically, or is there any clinical application of lateral force transmission that is being tried to, or that people are trying to apply it to, or that people have this goal to use this lateral force transmission for something?
Yeah, I understand what you mean. I don't think there's an example of that. I think there is more. Um, well, with that, it could help us like understanding some of the consequences of surgical interventions. Like with any surgical intervention, we damage tissue. So if you do have a surgery that is invasive, at least, and you damage tissue, then often the response of our body is to kind of form new connective tissues, or like and in clinical terms, often like something like adhesions is mentioned, or scar tissue, of course. And that scar tissue is a response to the disruption of the tissue, but that scar tissue could have a major play a major role in the effect of the surgery. And the most, I guess, well studied surgery is then like a tendon transfer. If you transfer tendons, this is done, for example, with people that have like a paralysis of a specific side of the joint. If you have paralysis of only of um, your wrist extensors, then you have a wrist drop, and to correct for that, you can actually transfer the tendon of one of your flexors to the extensor side, and to kind of regain some of the function around your wrist. Um, but yeah, but this is a very invasive surgery, because you have to free the tendon, you have to free the muscle belly, and then you have to transfer move the muscle to a different location. Often that comes with a lot of connective tissue and scar tissue, and that could have like negative consequences of the outcome of these surgeries. But that's more like a negative side. You're asking for like a beneficial possibility of this mechanism. Um, I don't think it's like actively used like in surgery to kind of create to create adhesions that help. Um, I think we do use it in some cases in daily life, and then I come back to my example of the finger movement and finger control. Um, there we can actually redirect the forces to one or two fingers using this mechanism. So we can exert much more force with three fingers than based on the muscle mass that is connected to those three fingers. And that's really because some of the forces of the inactive fingers, of the muscles connected to the inactive fingers, is also contributing to that movement. And if you look at people that do like rock climbing, for example, you can find instructions, and the instructions say if you do like something like a pocket grip, so that's a grip with two fingers, then you should bend your other muscles. You should not extend it. So you should not do a pocket. You should do a pocket grip like this, but not do a pocket grip like this. And this is really this makes also sense from the perspective of lateral or myofascial force transmission. If you flex the inactive fingers, so like this way, you flex the inactive fingers, then the muscle bellies are positioned such that, and you kind of create this shearing between muscle bellies, that the force can be transmitted to the muscle bellies and tendons of the active fingers. There's only a few studies, but I think one has shown that you can increase the force on these fingers like almost up to 50% by doing that. This is a natural mechanism. It's not. This is a natural behavior. If you hold a heavy shopping bag, you will do something similar. if you hold a shopping bag and you can only use two fingers, then automatically the other fingers will be flexed, and that helps in producing more force. So this is a kind of a natural way of using this mechanism. Um, I don't think there's any examples of that. This is really like part of the instructions of a rehabilitation program or part of the instructions of a sports practitioner, um, with this mechanism in mind.
Do you think it ever can be, or if there's anything that we might find out if we're that we might find out that this might be applied in a scenario of like athletes or physical therapy?
But I think it does help in physical therapy or in rehabilitation of the musculoskeletal system if you realize that this mechanism could play a role. Could be in rehabilitation after, for example, such a tendon transfer surgery, understanding the effects of the surgery, and thereby also knowing what what you should target for. Um, the other thing that I've also focused on is on the sensory side of this, because it's you have a mechanical effect, but it means also that you have there's a sensory it has sensory effects. And our sensory system, our muscle centers in our muscles, so the muscle spindles and the tendon organs, they're very sensitive to picking up local changes in the state of the muscle. Um, so they can also also our nervous system is using that information to control our muscles, and um, yeah, this information is also processed by our nervous system somehow. So that's what I'm now thinking about. Like, um, how can our central nervous system use this information to control our muscles? I think you can also, reverse it in a different way. If you like phrase it in a different way, say like, does our central nervous system really know about individual muscles, or is it only learning the mechanical consequences of activating a combination of motor units, and it doesn't matter which muscle these motor units are, as long as somehow the force gets on the right point and produces the wanted movement. Um, I'm not
That's
sure. That's a like understanding the central nervous system is a bigger challenge, I think, and it becomes a more philosophical question. But I think it's interesting.
definitely it's definitely interesting to think about it in that sort of way. I wanted to ask, do you think you could elaborate a little more on the clinical point of how lateral force transmission is important for muscle damage? Because I have seen stuff where because force is transmitted longitudinally and laterally when we activate and generate force with our muscles. Uh, this lateral force also affects structures in our muscles that causes damage. This is more so like skeletal muscle eccentric damage rather than
Mhm.
like an actual tear at the myotendinous junction. So yeah, I would see lateral force transmission, and because force is transmitted laterally, it affects structures both longitudinally and laterally in the structure. But you mentioned it was important. It's an important mechanism to also maintain structure, to anchor these structures post damage. I don't know if you mean post eccentric damage or more specifically post surgical damage.
Well, this could be eccentric damage, right? With any damage, if you have degenerating muscle fibers, then you have pieces of muscle fibers that cannot really contribute to force production. So there have been very controlled experiments where muscles were like actively damaged, and then they looked at like how would the muscle tissue respond to this. Um, and one of the things they found is that uh, that there is a kind of a mechanism that creates a bypass surrounding this damaged area, and so temporarily the the proteins involved in these lateral connections, so like integrins and dystrophin, and they get upregulated. So you see that there is like a higher amount of these lateral connections surrounding the damaged area. That creates a bypass, so that means that the forces that it creates capacity to transmit forces surrounding the damaged area, and that you kind of unload that area without having mechanical consequences. Because if you can still transmit the force around it, that means that you do not necessarily need to have force loss, right? So if you consider that the number of fibers acting in parallel, or the sarcomeres acting in parallel, would stay the same, then you do not necessarily need to have force loss. Of course, there's other mechanisms playing a role, like you will experience pain, and then that is also having effect on muscle function. But I think it's a very neat mechanism to maintain maximal function. It might not be 100%, but a lot, while also creating an unloaded area for the tissue that needs to be regenerated and healed. And it's also shown that if the tissue is healed, that these lateral connections are removed again. So maybe that's also partly an answer to the question we started with, that is it mainly lateral or longitudinal? Well, in this specific series of studies, they found an increase of lateral connections with damage, but also a decrease when the muscle fibers were healed and the longitudinal pathway would be available again. So that might give a hint towards that question. So this was a very controlled experiment. But if you look at more like the news, and you follow some of the athletes, then sometimes you read about magical like healing, or like there's so much damage in the muscle, but the athlete is still able to perform more than expected. Yeah, I do think that this mechanism then is also kind of can play a role in minimizing the functional effect, minimizing the impact of an injury, and allowing for repair in that site. That's one of the possible benefits of this mechanism. And of course, we as humans, we can go to the hospital, we can go to a doctor, or we can just kind of take some rest and make sure that we heal. But if you think about the animal kingdom and animals that need to escape from predators, if there's a mechanism that keeps these muscles limit the effect of an injury when they are bitten, or when they are chased by a cheetah, for example, then that might help them in survival as well.
I think that's pretty cool how the body would use all these different things or factors to improve its function or work with it. So do you have any idea of what the research might look like in the future for lateral force transmission? Any future directions that you might like to see, or that it's currently being working on that hasn't been published?
Yeah, so what I mentioned is that, especially for the translation to the work on animals to the human situation, I think more work needs to be done during active muscle contractions to see the effect. There might be more possibilities. One of the more recent techniques is like shear wave elastography. So both with ultrasound or MRI, you can get estimates of basically the velocity of a shear wave, and that shear wave means something about the stiffness or the force that's being produced or present in the specific tissue. So we have a little bit better tools to understand whether there are changes in the mechanics. The earlier studies focused mostly on looking at deformations, so using ultrasound, for example, to see if moving one muscle causes deformations in the neighboring muscle. But deformations are not always very informative about the mechanical impacts, right? So you can have a lot of deformation, but with very little force, or you can have hardly any deformation with a lot of force. So this really depends, of course, on the stiffness of the tissues. So having measures that say a little bit more about the mechanics and having these non-invasive measurements available, they could be applied more in the future to test this for more conditions in the human body, and also maybe more different specific muscle groups, because the number of muscle groups tested is also very limited. I think from my perspective, I think the hand and finger system is still very interesting. It's a very complex system, and we do have a lot of models of our hand and arms, also controlling fingers. But of course, these musculoskeletal models do not have any of these interactions between structures included. And as I already said, I think in some cases these interaction might be beneficial, but to understand the benefits and maybe explore the benefits, it would be good to also build this into musculoskeletal models. So that's some of the work I would like to continue with. And also because this could be important for designing robotic arms with fingers, or like prosthetic devices in which fingers are included. If it has a control advantage, then it might also help it in the design of these kind of apparatus.
Regarding the active muscle contractions, do you think that lateral force transmission only occurs in an active state, or like in a really intense passive state, or with high passive tension? Because I know this was somewhat of a debate, but it was said that active muscle fibers cannot transmit force laterally to passive muscle fibers, or muscle fibers that aren't active within the muscle. Do you have any thoughts on that, if maybe that's possible or if not really?
Yeah, so the interaction between muscles and whether forces can be transmitted from one structure to the other, of course, depend on their stiffness. And if you have if there are two pathways via which the force can be transmitted, and one pathway is very stiff and the other one is very compliant, then the stiffest pathway will transmit the greatest portion of the force. So in that sense, if you have an active muscle fibers sitting next to passive muscle fibers, then you might see, for example, a lot of movement of the passive muscle fibers, but not necessarily that means that there is a lot of forces transmitted to them. And that's the same between an active and a passive muscle. You would not expect a lot of force being transmitted from an active muscle to a passive one, just because it's a very compliant structure. The only thing that will happen, there will be some deformation, so there will be some movement of that structure because of the forces that pull on it, but it will not include a lot of conduction of forces. And that's also it's an interesting question, because one of the topics that, or the conditions that we are not fully sure of, is like how does that work within a muscle? Like, do we have always different muscle fibers? We're not always activating all muscle fibers, for example. So we have a combination of active and passive muscle fibers. How does it affect the function of the whole muscle? also, especially if you then have a combination of like muscle fibers that have more like fast twitch properties versus muscle fibers that are more slow twitch. Yeah, how can that be working together? I think we still have several questions on that.
So it's possible that some force from an active muscle fiber is transmitted laterally to one that's in a passive state, but it's likely very, very small if it
Yes.
does.
Yeah. 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 I
Yeah.
think so.
So, Dr. Maas, we are coming close to an end. Just as a kind of conclusion for lateral force transmission, correct me if I'm wrong, but from what I was able to understand, um, it's likely that most of the force is transmitted longitudinally, I guess, in a healthy muscle, but depending on different factors that have been influenced with the muscle or that influence the structure of the muscle and the methods of papers, that force can now be transmitted laterally, or more of that force can be transmitted laterally than longitudinally. And for clinical relevance, there is some clinical relevance for lateral force transmission, and likely with future directions, it can become more impactful to uh, healthy individuals such as athletes, and it's more likely more relevant to physical therapy for the moment now, right?
Yeah, I think so. Yeah, I think um, yeah, I think we do not know enough to really um, yeah, give advice on training differently because like really taking advantage of this mechanism. But we can say something about, well, preventing this mechanism or limiting the effect of this mechanism in, for example, surgical interventions.
Yeah, and that's kind of why I wanted to make a podcast about this, because I don't really see it talked about a lot, and I think it's such an interesting mechanism that our body has that I'd like to see more talk about it. I'd like to see more people interact with this or read more into it. So, Dr. Maas, if do you know where people can find you if you're on social media, or any books that you've written, or anything that you speak more about this, maybe any popular papers that you published?
Well, yeah, there's several papers, and we recently published a review also together with Taya Fini, um, kind of having a broad understanding of what we currently know about these concepts, both from more animal models as well as studies in humans. So there are some reviews papers that I published in the past years. Of course, I will visit conferences, as I indicated. I will also focus, well, redirect my focus a little bit more towards understanding the sensory consequences of muscle mechanical and structural conditions. Um, but yeah, like on all these papers, people can find my email address, and I'm always happy to answer questions. Well, you also found me the same way. So I did not write a book. There are books where this concept has been introduced, right? So those books also related to like more like the fascia system and fascia like therapies, therapies that really are directed towards the connective tissue system in our body. Um, yeah, this type of force transmission is really in line with people's thought about how the connective tissue systems also connect muscles to each other, but also connect organs and the whole body. So in those kind of books, you can sometimes find these theories. But yes, I'm always happy to answer questions, and I'm happy if people reach out to me.
Awesome. Well, I'll make sure to add the link to one of your popular papers or recent reviews for anyone who wants to read into it. It might be a difficult read for some people, but I think it's still worth a try. So thank you again, Dr. Moss, for your time. I hope you guys enjoyed this episode, and I will see you guys in the next one.